السلام عليكم ورحمة الله وبركاته. طلباتنا الأعزاء طلاب صف سادس، اليوم راح نتكلم عن موضوع جديد اللي هو موضوع الميل infertility. كلش مهم الموضوع طبعا، ممكن تواجهوا بحياتكم إن شاء الله العملية مستقبلا. So to start with, what is the definition of male infertility? It is defined as the inability of the couple to conceive within a period extended more than 2 years with the presence of unprotected intercourse. It means that without the use of traditional contraceptive method. About 40% of the couple infertility is related to the male and 40% related to female. 20% of the infertility has both male and female factor infertility. So I will discuss in this lecture how we can deal and how we can manage a patient with male infertility, because our concern in our urological field is the male infertility, not the female infertility. Suppose that you are in outpatient clinic and a couple come to you and the male said that we have more than 1.5 year or even more than 2 years since marriage, and we have no pregnancy, or we get no pregnancy. In this condition, we expect that we are dealing with a case of infertility. For our sector or for our specialty, we should deal with male factor infertility. First of all, we have to take a complete history from the patient, and the history including even the general history from the patient, but I will focus on the history which may relate to male infertility. First of all, we should ask about the patient age and patient occupation, and also residency of the patient. For sure that the occupation of the patient may be related also, or may be associated sometimes with the male infertility. For example, those patients or those population who work in certain chemical industries or in certain area which contain ionizing radiation, like in the hospital, I expect there may be some sort of effect of these hazards on the testicular function and may result even in infertility. Also, we consider the timing of the intercourse, and we ask the couple about the timing of the intercourse. All of us, we know that the ovulation usually taken or happened between the 12th and the 14th day of the menstrual cycle. So the best time of the intercourse should be at the mid period of the cycle, and since the sperm has the ability for being alive in the female genital tract for more than 48 hours, it's preferable to advise the couple to have an intercourse in every alternative day in the fertilization period, and the fertilization period extended from the 9th day to the 16th day of the menstrual cycle. So the best way and the best fertilization period extended from the 9th into the 16th day of the menstrual cycle. And here is the effect or the effect of the timing of the intercourse, which should be taken during taking history from the patient. Also, from the history, we can ask him about some behavioral activities like smoking or alcoholism, or maybe sauna practice. So all of these behavior can affect the function of the testes. Maybe the smoking, because of the toxic material that presented within the smoke, can affect the testicular function. Alcoholism, because of the androgen degeneration, or androgen can affect the androgen in general. It may relate in loss of libido, and also maybe erectile dysfunction, or even affect the testicular function. And also sauna practicing also may be associated with an increasing of intratesticular temperature, which resulted finally maybe in the poor sperm production and poor sperm quality. Also, we should ask the patient about the ability for making intercourse, or we should ask him more precisely about the potency state of the patient. Sometimes maybe impotent patient also, the first presentation of them is the infertility. So we ask him about the potency and ask him about the action during intercourse with his partner. Also, we can take a drug history from the patient. Certain drug may affect the function of the testes, and one of the most drugs that affect the function of the testes is the anabolic steroid, which is used to be taken by the bodybuilders. We insist, or we should look about the evidence of taking androgen or anabolic steroid, because the androgen can affect the hypothalamic system, and the resultant decrease in the follicular stimulating hormone and luteinizing hormone, which finally may result in the decrease in the sperm introduction, and may affect the quality or the motility of the sperm. Other drug, maybe we have maybe cimetidine, which is used as antiemetic previously, also affect the renal function. Certain diuretics like spironolactone, those both cimetidine and spironolactone can affect the androgen, or affect the level of androgen in the serum, which also may result in the decrease in the testicular function. Cytotoxic drug or chemotherapeutic agent also may have a transient effect of on the testes, because it may kill the spermatocyte, or may kill even the mature sperm, which result in the also which will result in final infertility for the patient. Also, we should take a surgical history from the patient. Sometimes hernia surgery, or even history of undescended testes, may result in the future in the infertility. Sometimes damage to the vas deferens during hernia repair may result in the male infertility, or even the presence of undescended testes also may result in male infertility. So surgical history is important, especially regarding the scrotal injury, scrotal surgery, and inguinal surgery. I will speak a little bit about the undescended testes. Actually, undescended testes consider one of the common urological condition that affect the neonate in a percent 0.8 per 100 of the newborn. 0.8 per 100 of the newborn. The testes could be outside the scrotal canal, anywhere scrotal sac, anywhere in the inguinal canal. Could be maybe near the external ring, or maybe in the inguinal canal itself, or maybe near the deep ring, or even intra-abdominal. Most of these testes will respond easily by giving androgen supplement for the patient, for the neonate, and result in about 80% of them would descend normally in the scrotal sac. But the effect of the androgen, when I said androgen, I mean giving pregnal injection, which is the luteinizing hormone. This synthetic luteinizing hormone will stimulate the spermatocyte or seminiferous tubule to produce androgen, and this will result in descent of the testes in the scrotal canal. But sure, it should be given in a specific dose and for a limited time of period to avoid premature puberty. So 80% of the patient with undescended testes will respond to this luteinizing hormone, but sometimes 20% of them may require surgery because there is no any response to luteinizing hormone, and the surgery is done by orchiopexy. But I have to say that even those who respond to luteinizing hormone, releasing hormone, later on may require surgery because sometimes maybe reascend upward in the inguinal canal. Time of surgery for undescended testes should be done between the age of 6 months up to 2 years. Because any delay after the 2 year it may result in permanent damage of seminiferous tubule. So we have to do the surgery before the 2 year age for the child or for the neonate who has an undescended testes. Now we return to the history again. We said that the history of surgery in the inguinal canal and surgery in the scrotum is very essential to exclude some causes of male factor infertility. Also, we should take a family history from the patient, because sometimes infertility may run in certain family, especially those with rare syndromes like Kalman or Klinefelter or even cystic fibrosis, and those family usually presented with male infertility. After completion of taking a detailed history about which is specific for infertility, we should change, or we should switch into examination of the patient. And the examination in general, we should do general examination for him, and later on we should do examination which is specific for infertility, because our subject is male infertility.